Hello, I'm Donal Macaulay and welcome to medicsvoices.com, where we talk to the key opinion leaders around the world on health and medicine. Today we're in Quebec and I'm talking to France Legare. Tell me a little bit about your career trajectory.
Well, I don't know if there has been a plan a priori trajectory. I hold a first degree in architecture. It was not possible for me to enter medicine at a younger age, so I entered another profession that was of attraction to me, which blend, I would say, we'll call it science with a more artistic aspect, creativity, if I might say so. And I loved every moment of it. I certainly got from architecture that you need to be what we will call client-centered and be extremely sensitive to the context. So just to say that I see much more similarity with what I'm doing now than maybe one would expect from looking outside the whole profession. So now back as being a clinician, and I was yesterday and the day before, I mean, you need to be client-centered, and this is definitively one of the key principle of being a general practitioner or family physician, as we say here in Canada. And you need to start from the perspective of the person coming into your office. I studied in family medicine and I started to practice in 1990. But as soon as I started my clinical duty, I also entered the master's degree in public health, which I did part-time at the time, as I was a young GP and starting a practice, etc. I've been extremely fortunate and lucky, because there's a lot of luck into this also, that I met the right people. I'm still within the same clinical team as in 1990s. And then when I started my master's degree in public health, I was very fortunate again to actually cross the path of two very exceptional individuals at the time. One was a health service researcher with one of the best expertise in behavior change. So he introduced me to studying behavior change. His name is Gaston Godin. He held a Canada Research Chair at the time in the field, and Sylvie Dodin, a clinician in women health. So again, also very grateful to her. So I was very lucky because with them, I really learned and got my first very basic tool to do research with them.
What strikes me is that you started off with architecture, which was very creative and client-centered, and then you moved to public health and you did your PhD in population medicine, which is a very different angle to healthcare.
So I was a clinician at the individual level, which is being a GP, so I meet with people on a one-to-one. But yes, I had some interest in public health, or we call it also sometimes community health, because it deals with the community, okay? You need to understand better the population that you provide service to, and you're being exposed to a more social aspect of health, those social determinants of health, which are quite important. One being, among others, behavior. That's the connection. And being a clinician, again, I stress that I still see real patient. We know that sometimes we have a need for a toolbox where we tell patients, or actually we discuss with them a need to change a behavior of some sort, either having to take a medication, a treatment, but also nutrition, exercise, etc., etc. So it's very, very connected to me. And when you do those type of degree, obviously you get exposed to other things, and I got exposed to other aspect, but that was the one where, as I said, I put a bit more time because my supervisor introduced me to how do you study behavior change and how do you intervene to change behavior. So this whole idea of motivational interviewing, etc., theory of planned behavior, etc., which is quite useful as a toolbox as in the one-to-one as a clinician and also as a public health officer. So
Well,
for me, everything is connected.
yeah, I mean, that seems a very nice opportunity to talk about your main research interest at the moment, which is
Yeah.
shared decision making.
Yeah. So that's it. So thank you for bringing it. So I went from changing behavior, which I still have I would suspect the toolkit to work on, to actually helping people make informed, we say, value congruent decision. Because at the time, we were trying to change the prescription behavior of doctors. We were trying to change the, sorry to say, adherence to medication of patients. And that's about those same years, so mid-90s or late 90s, when I met with Annette O'Connor from the University of Ottawa, who actually got to be my PhD supervisor a few years after. And I was then struck by the fact that, it was the main idea was, well, there's many options in health, and you may not sometimes be well equipped to actually make certain that an option is much better than another one, especially this whole idea of prescription of drugs or uptake of drugs. So why not present the option to patient and discuss them with them, and discuss the risk and benefit, etc., and what matters most to them. So I went from actually trying to change behavior of prescription and uptake of medication to actually trying to emphasize informed choice that match what matters most to patient. So that's the shift also that kind of naturally occurred, and that brought me to shared decision making, patient decision aid, etc. And that's the topic I chose actually when I did my PhD in population health, which again is linked to the health of the population, obviously, but I did focus on how do we help clinicians in primary care to actually integrate the patient voice in making decisions about their treatment or diagnosis tests, etc.
I'd like to ask you about something very different now. Are there issues relating to the Francophone and Anglophone research community?
I think when you think in your language, and there may be something that is quite sometimes challenging to say it's universal and everybody will understand. Even with the field I'm in, shared decision making, we've done a what I'll call literal translation, which is prise de décision partagée, but it doesn't ring the same. And even this morning with my student who was defending part of her PhD thesis in French, something similar was happening because there was a lot of question. One of the key interviewer was from France, another one was from Quebec, and even the words matter. What do you mean? Define this concept. Is this what this means, or you mean this rather? Okay, so my understanding is that it may actually be connected to some topics of interest that you will have, so to your capacity to actually push forward. But I'm not, I wouldn't be, it's observation. So I'm not, a neuroscientist, but yeah, when you speak words in a specific language and you think in a specific language, you try to express yourself in a specific language and you're being asked, is this what it means? Obviously, there is some, not divergence, but differences. Okay, now in health services research, it's even more important to some extent because when you do what we call knowledge translation, mobilization of knowledge, whatever, well, if you work with your policymaker in the province of Quebec or my colleagues at the clinical sites or patient, and French is their first language, and that's where they feel the most competent with, you need to run your project in French, but you need to co-construct it in French if you go the way of the co-construction. And sometimes it's quite hard to bring it back and forth. I've been involved with many pan-Canadian network and project, but it's not that easy. There are differences, and you need to be cognizant of them. And everybody knows that in Canada right now, one policy is reconciliation. So, First Nation, multiple different languages, and they say it very clearly. It's something that is of great importance for them to do research, to stay healthy, etc. So I would suspect that it has an influence, but it doesn't mean that we cannot talk to each other.
Now let me bring you back to your own research.
Yeah.
But actually in a different angle, because I'd like to ask you about your recent awards, because you've had a number of recent awards, and the most recent, I think, is the Chevalier. Tell me a little bit about it.
Yeah, in English it would be knight.
Yes, indeed, yeah.
Yeah, so it happened last year, which would mean that a year prior to that, a group of people know about my work and actually feel that it has an impact, actually ask if they could submit my candidacy, if I might say so. And it was built around the contribution that they felt, because sometimes, especially during the COVID, I feel that there's 3 years of my life I haven't seen gone by because I was a clinician first line in person a lot of the time. So I didn't see very much of the world. And so they felt it has an impact. They felt they wanted to put it forward, but I would suspect also that any award, and that's my vision on this, has to do not with your own person and persona actually, but that you bring the voice of others you've worked with, or actually that you may actually give a voice to, which is, I'm a GP, and again, that was stressed as a characteristic. So they wanted to also praise GP, if I might, okay? And then there was the voice of the patient. And actually that year, which was last year, I got this award at the same time as a partner patient got one as well, okay? So that was also something that actually I think that so there's a group of people, it's not me who submit the file, but I think that the committee wanted to heighten elements that are not necessarily linked to my own persona, but are linked to something else that they feel they want to also highlight, which mainly was to be a GP and being with my other colleague who was a partner patient, to be that the society be reminder that the patient voice is quite important. That's how I see it and I approach it.
It's a wonderful achievement, and it's a great tribute to primary care, family medicine, and it's a great honor for everyone in family medicine. So congratulations, exactly. And it's just wonderful. So let me finally ask you a little bit about the future and what your research ideas are for the future, because your research funding has just been renewed.
Yeah. So I hold a Canada Research Chair. I've been doing so since 2006. So 2 cycles of what called the junior, which is level 2, and now my second and last cycle of senior, level 1. So yeah, I'm very again grateful to Canadians. Always being reminded that I do this because Canadians work very hard themselves, and I owe them. So so our focus is maybe threefold, as we say, is the idea of patient engagement, providing the voices of patients during the clinical encounter or outside the clinical encounter, anyhow, to have what matters most to individual when they make a health-related decision, is something we also want to scale. So we're very much into scale right now. We love that area of implementation science, might say so. So scaling paying attention to those in societies, Canadians who have the least voice in making decisions about their health, because we've done a couple of surveys and we have a sense of where it's not happening at all and where it's happening a little bit. So we're still doing this and want to do it further. And as you mentioned, it's you. Thank you very much. I've been exposed to many graduate students coming from French-speaking Africa. And French is also gaining into visibility to, if I might say so, internationally. We suspect there's about 320 million French-speaking people in the world. So we're also now working much more with the Global South and focusing a bit more with the French-speaking Global South, where different issues pertaining to patient engagement, science of scale is also of great, not only interest, but they have the skill. So that's another focus. And the third focus is this idea of training the next generation, so capacity building. Capacity building within the medical field, obviously, because I'm still, so when I was doing clinical work yesterday and the day before, there was residents in family medicine with me. So the medical community, obviously, but also graduate students that again, I'm very privileged to accompany and who comes from a diverse country or culture. So we can build capacity and help them, launch their own, I wouldn't call it only research program, but their professional life and future network. That's really the focus right now.
That idea of capacity building and future-proofing primary care is a wonderful note to end on. Francis, it's been an absolute pleasure talking to you. Thank you very much indeed.